Are you looking for a podcast where you can hear from real people regarding their real dental drama? If so, then you've come to the right place. Join hosts Bethany Petty and Dr. Rena Kuba as we dive into the solutions we've created and the mistakes we've made while managing dental drama. Let's get started.
So this is weird because we are not in your closet, my closet, or a car.
What's wrong with us? Do we even know what to say outside of those zones?
We do. We just need to focus. And so here we are. We're doing a live podcast. And the only difference is we're dressed up, we have makeup on, our hair's done.
The only difference is all of it. It's all different. Yeah.
Exactly. But we will stick to our usual format of how did we know what we wanted to record for this podcast? We didn't. We just brainstormed that right before starting here, kind of going, what's going on in your world? What's going on in my world?
Yes.
And we decided on, you guys ask a lot of fantastic questions on Facebook and through our Managing Dental Drama other forums. Like, we get a lot of really good questions asked. So we've tried to compile those and seeing if we can answer those here. Yeah. So I pulled one.
Yay! I'm ready.
Let's do it. And I want to talk about this one because I think there's a lot of offshoots with it that may address some other questions that come up too. So I'm going to read you the question.
Let's do it.
You ready?
Ready.
Okay. Are you tracking your client retention metrics? So I'm going to pause right there. I'm going to say we are. But not we, she.
Yeah.
Luckily, she's there because I think if you had asked me this, I'm like, I think we are. I'm pretty sure we are. But I know we are because you send me reports and
that you don't read.
That I'm just like, they bring me anxiety because I'm like, what if this is a bad number? So you track it all, but you summarize it for me at the top about not only how is the retention going, but what are some strategies to fix said retention. So it's like you're managing all of that for me. So when I first read this, I was like, and you're like, no, we do this, this, and this. So we'll talk about some of those things.
For sure.
Are you tracking your client retention metrics? It's easy to focus solely on new patients, but it's just as important to track how many of your current clients are sticking around. Having the right metrics can help you identify what's working and where you need to improve. Tracking things like repeat visits, average client tenure, and satisfaction surveys will give you a clearer picture of how your business is performing in terms of client retention. So I don't really know, like, from a listener perspective, what's your actual question? Other than you're asking me if I track retention, which I do, and it sounds like you do too. But I think the bigger point is there's a lot of people that they think about it, but actually doing it is a whole nother like, oh my God, when do I have time for this? And I think I mentioned it in one of my digest articles. Like, okay, so you have, say we go through right now, we're going to go through like whatever you do to look at reports. Okay, you've got the reports. Now what? Yeah. Like, what are we doing with that information? So I'm hoping we can kind of unpack some useful tips that will help people like know what to do with that information, or at least pick out a strategy and say, okay, we may not try all of this right now, but let's try this one. And I will say, even though I'm not the one doing the tracking, but I can't stress how important that is, because if you think about, say we hit 10 new patients this month and we're all like, yeah, rah, rah. But what are we doing? What are we doing if we're losing 12?
Right. How do you solve the problem?
How do you solve the problem? Like there's got to be a plug on the other end, so they're not just all coming in and going right back out the door, and we're spending all this money to get you back in the door, and then you're right back out. So, I think we all like to believe we're doing great.
I think everybody assumes they're doing great.
Yeah, and it's like unknown. I don't know, so it must be fine. Yeah. Well, Mary was on the schedule last time, and she's back, so everybody else must be right. I know for me personally that is a problem. Like I start going, I think they are, I hope they are, because here's the problem: if they're not, then why are they not? Yeah. And somebody like me, y'all know, I tend to be very my emotions And so I'm like, what did I do wrong that Mary's not coming back? What did I not meet to meet her needs? It must have been me. She must have not liked the way right?
Yeah.
So to me, that is one reason why a lot of us don't look at it, because one, we don't know what to do with the information. And two, there's a high likelihood that it's like, what did I do wrong that you didn't come back?
Right.
And so facing that and navigating that is just yucky.
Yeah.
So it's like, never mind.
You'd rather not know.
I'd rather not know.
Yeah.
I'm going to assume that some of these patients we've been seeing, and I recognize those names, and so we must be fine.
Yeah. You know, it's interesting too. I feel like the busier the practice is, the less likely they are to focus on retention. Because to your point, it's like, we're fine. Look at how busy we are. We don't even have time to think about retention. And I think that's where it gets scary for a lot of practices.
So then the argument that I could see a lot of people going, but yeah, if we are busy, then what do we care about the retention? Because clearly we are booked, so we don't need those people, or even if those people did come back, we don't have a spot for them anyway. So does that matter? I'm busy.
Yeah.
So what would be your answer to that?
My answer to that would be, why do we do blood work? You know, I feel fine. Everything's totally fine. I mean, like, I sleep, I eat, I walk around, I'm good. But we do blood work by the doctor's orders because there's things underneath the surface that we may not even know are a problem. And same thing is true for retention. To me, retention is the tool that shows us whether or not a practice is truly successful or not. And there's going to come a time where that volume may go away. And at that point, let's say you've been in a really busy practice, the schedule's crazy, but you haven't noticed this slow bleed. And then all of a sudden you hit a tough month and you're like, what in the heck happened? And you go and start to look into retention, which is one of the first places I would say to look into. And you see in there like, oh, wow, we've been losing patients for a very long time. And to me, that's a systemic problem. It means there's a lot of things wrong with what we're doing. Not only we're not pursuing these patients to keep them, but do we have a cancellation problem? Do we have a customer service problem? Do patients not trust our providers and therefore they're just quietly leaving from our practice? So it to me is a health marker for the practice.
Correct me if I'm wrong on this, but is it also like, I start thinking like, did we do some sort of promo that brought people in, or are we in network with all of these insurances and that's why they're coming? And then now I'm hitting a point where I'm going, oh, I'm so busy. Maybe it's time to drop an insurance.
Yeah.
And then that's when you figure out like, wait a minute, I wasn't that busy with like super productive. It
Right.
looked like productive, but it was just more volume.
Yeah.
And now I'm like, I can't sustain the volume. Like it's hard to find staff, or it's whatever. Like whatever,
Yeah.
you're like, okay, I need to start figuring out how to get more seats available. Because like right now, my recare, if you want to get in for recare, it's another 4 months or another 6 months. Well, that's not good. Or a new patient can't get in for another 3 months or 4 months. And you're like, oh man, I need to figure out how to slow this. I'm doing so great. I need to figure out how to slow this down. Well, I'm going to drop this one insurance. Well, then you're thinking that you're going to lose, 20 patients because you're going to drop this insurance. Well, you really lost
120.
Yeah, because a lot of them weren't coming because of the care you were giving. They were coming because of the insurance.
Yeah.
And so does that...
Well, and to me, retention's always important, but it's especially important before a big decision, like an insurance change, a location change, adding an operatory, something like
adding
that.
a doctor.
Adding an associate, adding a hygienist, adding an additional team member. I'm like, don't do any of that until you know who your patients are. Are we retaining them or not? Because you can get yourself into a hole real quickly because you just assumed that everything's fine and it wasn't. And again, it often takes just like one or two little tweaks in the practice to then reveal a problem. So if you just stay status quo, hey, it could continue like that. I don't know. But one little thing happens. We hit a snowstorm, or heaven forbid, we go back to something huge like the pandemic, and then all of a sudden it blows the practice up for a minute and you're left trying to put the pieces back together of why was this practice not as solid as I thought it was. And so before any major decision, even any minor decision, especially hiring somebody, I would dig into retention before you even go there, quite honestly. And I think you said this earlier, retention to me is so much more complex than we make it out to be. I think people I don't know. I would think some people are like, is my schedule full? Okay, I'm retaining patients. But to me, we've got to look at how are we retaining patients? Like in your practice, are we retaining patients through the hygiene department? Are they coming back regularly for their cleanings? And when I say regularly, I mean on time. So why does that matter? Why does it matter if somebody's on time or not? Well, because
on time meaning every 6 months.
Every
if,
6
if
months.
that's their protocol,
If that's their
every 3 months, if
frequency.
that's their, yeah, okay.
Yeah, if you've said, hey, no, they're good for every 6 months, well, then if they are coming every 8 months, first of all, that's not what's best for the patient, because you said they need to be here every 6 months. Kind of industry standard is every 6 months. So then if they're not coming for every 8 months just because they plan it around school holidays or whatever the case may be, yes, we've retained the patient. That's not a huge alarming situation. But over time, if you have a lot of patients that just kind of naturally default to 8 months, 9 months, you trace that out over a 2-year period of time, and you're having to add that many more new patients to supplement the loss of those patients on their regular interval. So even looking at, are they coming back, but are they coming back on time? Challenging the question of, okay, we said to little Johnny, who constantly, he just never brushes his teeth, we told mom he needs to come back every 3 months. Why is Johnny not coming back every 3 months? Why is he still on a 6-month rotation? Is that something we did? We didn't communicate that clearly to the business team or whoever was scheduling him. Is mom just refusing that? No, I'm just going to go with the 6 months. So there's so many things that can cause it to be delayed, but if we're not taking the time to even realize they're delayed, then we're missing an opportunity. So hygiene's one aspect, but also treatment is another aspect, where we could be retaining them consistently in the hygiene department. If they're on a 6-month interval, it's like, great, they're here on time every time. And they've had fillings that we've talked to them about for the last 2 years, and they haven't taken one step in that direction. That to me is a question of concern, honestly, because that means they're doing the free stuff because their insurance pays for it. But when it comes to things that they actually need to do for their health, do they not trust us enough to do it? Have we not presented good financial options? Is the doctor kind of clunky and how are they being clear that the patient needs those fillings? Do we have good documentation that they need those fillings?
Do we have intraoral photos? Do
Yeah.
we have like other tools that we could use to really convey that this is a need?
Yeah. And that's where we can lose this, because if we use the example of a patient that needs a couple fillings, which is every doctor's favorite procedure, then we're looking at the schedule and like, man, we got a great productive schedule. We've got some crowns, we've got some surgeries on there. We're feeling really good. And we don't really care that the fillings didn't make it on the schedule. I get that, but that's still indicating a retention problem. So we're happy to kind of gloss over that one or not even pursue that patient because we're like, it's just fillings. He'll be fine. But it still indicates he never scheduled from the get-go. So trace it all back to go, what did we do wrong from the get-go? And is this pervasive or not? Is this just Joe because Joe's going to deny everything because Joe's Joe? Or is this, when we start looking into it, we're like, oh no, every patient that has a filling recommended to them doesn't pursue it. So then that's got to indicate we're presenting something wrong to those patients. So yeah, that's another avenue that we don't spend enough time on.
Even you saying that like just makes me think in my own office, like it's just something that I'm like, I can't make the horse drink the water.
Yeah.
Like I've showed you that your kid needs this. You came to me because you saw the black hole. You came to me because your kid was hurting. And we've got a strong patient base that doesn't believe in fixing baby teeth and a strong patient base that only wants whatever insurance is going to cover. And there's only so much I can do.
Yeah.
So my defenses do go up where I'm like,
why even think about it?
Well, it's not even why I think about it, but it's like, what am I doing about it? Because then if the answer does become, is it my treatment coordinator?
Mm-hmm.
Is it me?
Yeah.
Like just trying to figure out how I would problem solve those, I start going, well, it's the patient's problem, not my problem.
Yeah. Yeah. And I think it's normal to default to that because that is an easier solution. And that could be the solution. It really could. It could be like, hey, it's just the patient. And that solves my retention problem. And there's nothing I can do. I'm doing everything in my power. But I think if we don't know that that problem exists, then we aren't taking the time to even trace back and go, is there anything I could change? Because let's say it was your treatment coordinator. Let's say that as you started tracking treatment statistics, treatment acceptance statistics, and you go back and your treatment coordinator started in the summer of last year. And everything prior to the summer of last year, we had a 60% acceptance rate on treatment. And then summer to now, it's 32%. And you're like, ugh. So we were doing something before treatment coordinator. So it becomes evident that maybe something's going on with the treatment coordinator. Then what? Okay, when's the last time we observed her? When's the last time we've recorded her conversation with in your case, the parents? Does she need any kind of tools? Like, what's the rejection that she's getting in the room? Oh, let's say it's money. The parents always say they just can't afford it. Okay, treatment coordinator, what are your thoughts and ideas on that? What do you think the parents need to be able to afford this? Okay, let's look into financial options. Let's start tinkering around with, did that persuade the parent to move forward when you had that financial option available? So to me, even if we're like, oh, it all hinges on it's a person that's kind of sinking our retention through treatment statistic, you can still, there's a lot you can do to help that person.
So I think about a treatment coordinator we had a couple of years ago, and she was a little bit older, so I like that. She looked mothering, like she looked like she was very down to earth, and she had kids, and so she could very well be like, I'm kind of mama bear. This is what I do for my kids, and this is what I want for her. So on the surface, she was a really good person to be the treatment coordinator.
Yeah.
Because she was approachable and you could ask her questions and all of that. She was knowledgeable. She knew, she'd been in many dental offices before, but also pediatrics. Like she knew the terminology and what the procedure entailed and all of that. So in our eyes, she was really great. And she was easy to talk to.
Yeah. And
she exuded this warmth about her. Well, it was not going well. And she would be in there for like 45 minutes, an hour. And we're like, really shouldn't take this long. And she was defensive, going, well, I'm trying to build a rapport with this parent so that they do trust us, and I'm like, I mean, yeah, but also we've had other good treatment coordinators that do this and they can wrap it up in 15 minutes. So we probably just need to tweak what you're doing and figure that out. Well, come to find, and it took us a while to dig down, we finally realized, like, whatever she was saying, it was like, I don't think she outright came and said, yeah, I wouldn't pay for this. Mm-hmm. But that's really what we discovered was the ultimate problem, is that she would look at the estimate and be like, $3,000, I wouldn't pay that. Mm-hmm. So then she was really having a hard time with the parent. It's almost like she was agreeing with them, like, yep, this is a lot of money. Yep. Yeah, I don't know. Yeah, yep. And kind of leaving it at that. We're like, wait a minute, what? Like, well, so...
And she herself had a motherly aversion to IV sedation.
Yeah.
She herself said, I don't know that I've ever put my kid through that because there's so many risks involved with it. So she had not bought into the value of that treatment, the value of being able to put a child to sleep for the treatment. She just didn't believe in it.
Which ultimately to me says, well, then you don't trust us in this facility, because we've had the training. We have a great track record. You see what all we do. You've met our anesthesia providers. You've seen how great these kids do after. You've seen the ones that have been tortured and held down, and you've seen how well our kids do. And yet you still don't buy into it.
Yeah.
Well, then that's a fundamental problem in philosophy. And we're never going to see eye to eye because you don't believe. I think she would rather have her kid held down.
Yeah.
Or she rather would, like, have teeth extracted rather than restored. Which I'm not going to say is, that's certainly her choice as a parent. But when you are in the position to try to help the parent that does want these services, and you're not able to relate and help them, if a parent was like, my kid has to be asleep. Yeah.
Exactly.
But that's what the doctor's recommending.
Yeah.
And so she was inadvertently sabotaging. And it took us a while to see it because she was very covert about her feelings on things.
Until we really held her feet to the fire and asked those point blank questions. It didn't become obvious to us. And I think the timing is really important here, because 45 minutes to sit and chat with a parent, she was a very warm, empathic, connector type person. And so the longer she would sit and talk with that parent, the more her heart was, which again, that's not saying that we didn't have a heart when we recommended this stuff. It's just she would get so bogged down in their personal life stuff that she didn't have clarity of mind in how to present this treatment. And it led to a lot of patients, parents not moving forward with treatment. But again, that was one of those slow bleed things. It wasn't anything like, bam, in your face, all of a sudden we don't have any treatment on the schedule. It was something that the longer she was here, we were like, what's happening? And honestly, the treatment statistics showed that. We even set goals for her, like, hey, let's try to get it back up to this. And she wasn't achieving those goals. We were on it with her. I mean, coaching from the get-go, because we know how critical that role is and how critical retention is for a practice. And so we were pretty honed in on her from the get-go, but it wasn't until months and months into this that we're like, okay, there's something here that we're not picking up on. And yeah.
And sure as we removed her from there,
back up.
retention went back up.
Yeah.
If you're constantly looking for support, resources, and inspiration, you need to stop. We've put everything in one place for you. If you're looking for great resources, go to our hub where we've got everything you could possibly need. If you're looking for team training, then check out our free webinars. And if you're looking for monthly consulting but broken down into digestible pieces, then you need to become a subscriber. We've got everything in one place. So audio listeners, click the show notes and you'll find these links. Our video watchers, make sure that you click that QR code. Stop looking for what you need and go to the one resource that has it all.
Yeah. So I think treatment retention is absolutely important, even if it's the little stuff, the elective stuff. Elective is a great one. I was just in a practice the other day where I was working with one of his clinical assistants is the person responsible for tracking all cases after they leave if they didn't schedule, which to me, most offices do not have this. Yours does. This office, honestly, any office that I'm working with, I'm like, we got to have somebody thinking about this. But this assistant was new to taking over this job. One of the previous people went on maternity leave and didn't come back. And so we moved it to her. And it was really interesting as we were building that list of, okay, you got some cleanup to do because so-and-so didn't come back from maternity leave. First of all, I just love her passion for this because she, as a clinical assistant, she's been in that room. She knows how valuable that treatment is. She sees the results with patients. And so she's approaching that list in a very different way than the prior treatment coordinator did, who was at the front. That's not to say that either is better or worse. In this case, she immediately had passion because as she's looking through that list, she's like, I know these people. Like, oh my gosh, Mr. Jones didn't get his crown done. Like, I'm putting him at the top of my list. So she has a very passionate approach to that list, which I love. But we've got to be careful that whoever is responsible for pursuing those unscheduled patients, it's not just a, hey, Joe, notice you didn't schedule a crown. You want to go ahead and get that scheduled? That's not how we're pursuing Joe. We're pursuing Joe from a clinical standpoint that goes, hey, that tooth is fractured. We sure the heck don't want anything to happen to you. And so this clinical assistant brought that just by her connection with these patients. So even if we've got a good pursuit plan after the patient leaves, first of all, we need to make sure that's comprehensive, that we're not eliminating anybody from that list because doc doesn't like to do fillings. So we're not putting fillings on that list. No, we're clinical providers. At the end of the day, like we have to ensure that we're doing what's right for the patient, which is to pursue them. And so make it a comprehensive list and make sure that the person that is calling actually has some enthusiasm for this task. And I know it's hard. This is not an easy job to pick up the phone and call these patients. But if we view it as what it is, which is a clinical care call, it's not a schedule filling call, it's a clinical care call, then I think we can approach that with enthusiasm. And that then goes to our retention goal.
Which I think even in our office, we've got the person that took over scheduling these, and I think even one of the hygiene team members who kind of oversees things was like, well, I don't think she is, it's like she's checking a box. Did I make that call? Okay, so I called you, you didn't answer. Now I sent you the email, and now I'm going to do, like, she's going stepwise check. Okay, this patient still didn't respond. What's the next step? And she's just going down the tree. And my hygienist was like, I can't remember exactly what she said. She's like, I would approach it this way. Like, if the parent is like, I don't have insurance, or my insurance is changing, or whatever, she's like, unless the patient specifically says, do not call me, then we need to call them back. And I think that was kind of what it was. The parent was like, no, I'm not ready to schedule, or no, I don't, whatever it was. And the person doing it was kind of like, okay, and would punt it off. And my hygienist was like, you need to dig a little bit more. These kids are going to be hurting.
Yeah.
And so I think certainly from a clinical perspective, a lot of times they can see what this tooth is going to look like versus somebody, the front may not, but it's going and saying our job, why we walked in this door, was to take care of people and their health.
Mm-hmm.
And if we're not following up on that, we know what's going to happen.
Yeah.
So how are we trying to get this patient to understand? Now, did that patient go down the street to a different dentist who took their insurance? Maybe, but at least we're making that call to say, I just wanted to make sure your needs were taken care of. Mm-hmm. And so I think that's what we decided to do. Was then, I think now we're going to have, like, the first line of call is going to be the person who's in charge of that. But then if they don't schedule then the next person is going to be a clinical person. It's going to be a clinical person who's going to be like, let me just make sure, like, did you understand? Or is there anything I can clarify about the treatment for you? Yeah. Because we tend to see, and then they can speak from their own experience, because we tend to see kids with their faces blowing up. We're trying to go on vacation and now we can't, or whatever it may be. Yeah. Okay. So my question for you then, back to the original question of, do you track your retention? And I think most of us, if we've got a Bethany, we do. My guess would be, if you don't have a Bethany, chances are you are not tracking your retention, or you are tracking it, but then you are not doing anything about it. My gut would tell me, just knowing myself, let's start with, if I'm listening to this podcast going, oh God, how do I get started? So what would you say is the first place to start?
Yeah, it's getting familiar with the reports that you need to pull. So I've been thinking about this since you asked the question, how to be able to simply explain this. So I use the term macro micro a lot. I as a consultant, I tend to look into, when I'm in your office pulling reports, I tend to start really big picture, as broad out as I can span, to kind of see, looking down from up here, what are little spots that look interesting to me that I need to dig in further. And then the micro view is taking that subject matter, whatever I choose to kind of jump down into, and go, okay, let's look at this from several different angles. So I would say, first and foremost, we want to get a big picture macro view. And there's a couple things that we can do to pull those reports. First and foremost, you can pull a report that shows you how many patients you saw for any period of time. I think it's better macro-wise to go as big as possible, which I would do year-to-year comparison. So if you're just now starting to pull these reports, I might go back to 2023 and go, how many patients did we see in our practice in 2023? How many patients did we see in our practice in 2024? Did that go up? Did that go down? If it went down, it doesn't mean it's an overwhelming problem unless you had a whole lot of new patients that year. And then I would go, why the heck did that go down? Because if we had 300 patients that year, new patients that year, then why did we see 300 patients less? That means we actually lost 600 patients because we added 300 new ones and we lost, our total count went down 300. That's a pretty big problem. So how many did I see? And then pull one more year as a third comparison. Because you just want to see big picture, how many patients. That's the easiest, quick. Now, if everything looks like, yeah, I went up, let's not just assume it's okay. Because patients seen in most softwares, it also tracks the number of times they were in your office. So it doesn't usually count individual, like how many times was Joe and his family in our practice. It counts how many appointments did Joe have as a part of that number. So if Joe had an extensive treatment plan, it could be that it looks like we saw a lot more patients, individual appointments, but really Joe took up 12 of those. So I wouldn't just pull that and assume it's okay. But if I pull it and things went down, that would be a concern for me, especially if we have new patients. So that's the first picture. Yeah.
Can I stop us there real quick? Unless you want to come back to it. But okay, so that's the first picture. Let's assume we did see that down. Then what am I doing about it?
Yeah. So that's where we dig in. So even if the numbers look good, if this is your first time pulling them, I'm still going to tell you to go micro. So the macro gives us like a big picture. If it went down, there's a problem. We're going to do a lot of digging. If you pull
the digging's the micro.
The digging's the micro view. So once we pull down, so that's our big picture look. Now we're going to pull down, and I would track it in 2 categories. Although there's a third one category that I really like, but let's go with the 2 for now. So hygiene. If you're a practice that has any type of recall, ortho has recall, pedo has recall, perio has recall, most have some type of retention. The only one that doesn't have like a true prevention type program is going to be oral surgery. Endo.
Yeah. Okay.
Yeah. So those 2, we are going to go with just the second option. So hygiene, prevention, recall, whatever you want to call it. I would get in and I would take your first micro view to be a quarter. A quarter is 3 months. And I would compare, if I were to look at where it's a difficult time of year to do this. Let's just go, I'm just going to forget what time of year we're in right now. But let's say I were to look at January, February, March. I would want to look at how many recalls or how many hygiene patients we have due during January, February, March. Let's go with easy math and say that for those 3 months, it's 300 patients that we have due. Then I take that number, I'm like, okay, 300 patients were due. Now, how many were seen during that period of time? And you can pull that by looking at the procedures that were charged out during that 3 months. So I'm going through pulling those 3 months of procedures, and I'm looking at, let's say for your practice, it would be prophy adult, prophy child. For an adult practice, it might be prophy adult, prophy child, perio maintenance. For ortho, it would be their, retention, whatever they call it, growth evaluation, growth and development, whatever you want to call it for that. But you would pull those codes and go, okay, how many did we see during that particular time? And then if that number is 300, you're like, that's fantastic. 300 people were due and we saw 300 people. What often happens is we're off that mark a little bit. So maybe we saw 275 out of the 300. That to me is the best mathematical retention. So we're always aiming, industry standard is we want to always be at 90% or greater. So if the number that you pull is less than 90%, it indicates a true problem. If you're at 90%, I would say you're still not safe. We need to really look into this. If you're batting 98%, honestly, I'm thrilled with that. Could we bat 100? Yeah. So I would still say it's worth looking into, but there's not going to be a ton of room for improvement because people move. In pedo, people age out. In adult practices, people die. I mean, it's hard to retain 100%. So I would say 98% is it'd be hard to find areas of improvement. So if when you pull that, you're like, okay, 290 out of 300, that's pretty darn good. I would still look a little bit further and go, let's look at the previous quarter. Let's look at October, November, December. How many were due? How many? So let's say you're consistently low. This is where you go even further micro and you start auditing. Why? Who is on that list that's not scheduled? So Dentrix, that's the continuing care list. Eaglesoft calls it the recall report. A lot of them call them a recare list. So you want to actually look at who was due during that quarter that didn't come in. And you just go start looking at those patient charts and you go, okay, were they scheduled and then they canceled? I see this so many times when I look at this report. I'll see patients on there that were on the schedule originally and they canceled. at some point. It's the easiest way to lose patients in a practice. And so then I'll find people that just never scheduled their recall. Okay, what was our pursuit of that patient? Did they get emails, text messages? Did they get phone calls from us? How often have we pursued them? I'll be honest, a lot of times it's just the auto messages. If they've got a weave, for example, it's like, okay, they're getting all the weave messages, but they've gotten nothing else from us. And to me, that's a problem. So you want to do a microscopic view to see what's our pursuit of those patients. And then while you're looking at that, let's say you do have a really good pursuit program. Y'all have got a really good one. Where are the efforts that we're making effective? So let's say that we look and we're like, oh yeah, they got all of the auto reminders from Weave. And then also it looks like Sally called.
So when you say, how would we would look, where are you looking? Like for us, you go into our office journal because that's our system of where we document that.
Yeah.
Or Weave has a log?
Yes, Weave has a log. But if you're just logging through Weave, I don't like that. I like where it synchronizes in with the practice management software, because I like for all of those pursuits to be a part of the patient record.
Right.
It provides us with some clinical protection to show that, no, we've pursued this patient.
So then, like, for example, if Amy in our office called Miss Jones and then she made a journal note, but that could also be a skewing thing if you don't have a system where you're supposed to track that. Or if Amy was new and didn't know she was supposed to be logging that in the journal. So you might have some digging and then some questions.
Yeah. Let's say that Sweet Sally at the front printed out a recall list. And she's calling off that list, but she's just making all of her notes on that list. And none of that's getting into the patient record. So the pursuit could be there. We just don't know what the pursuit is because it's not attached to the patient record. So that's another aspect of this, that as you dig in, you may realize you have a documentation problem and you need to address that and get those items in the chart. So anyway, I would say big picture, are we growing in patient base? Micro, look at it quarter by quarter. Are we seeing a trend, or are we always off in quarter two? Because you can go back and pull this as far back as you want to pull. I'm like, what the heck is going on in April, May, June? Every April, May, June, we're down. Like 300 patients are due and we see 200. What in the world is going on? And we go and look, and our beloved hygienist, she takes a 1-month vacation every May. And we're always light. Or, oh, doctor loves to go to Alaska in May, and that's always his vacation time. He takes a couple weeks off. Now, eventually if that's consistently happening in quarter two, then eventually the recall numbers should go down to reflect that. We shouldn't have 300 patients due every single year if that's our norm. But if that was a new thing, or sometimes it's May, sometimes it's July, it just depends. But what my concern is let's say quarter one, we look solid. We're at 95% retention. Quarter two, terrible, 70. Quarter three, 95. Quarter four, 95. We've lost a crap ton of patients still by the end of the year. And so that we can't just look at one quarter and assume everything's okay. But if you constantly have a low quarter, dig in. Why is that? What's going on that's forcing that lower retention during those months? So that's how I would look into it from a hygiene recall standpoint. Then you've got the second category, which is what we've kind of been talking about, treatment wise. So a lot of the softwares have a treatment statistics report. I found that it's not super reliable, but it's still good to pull it, because it doesn't matter if it's unreliable. Like a lot of the reports I'll pull will show like a 12% acceptance. And I'm like, holy moly, that sounds bad. But when you look into it, they're tracking it by dollar amount. So if we've got a doctor that gives 3 options to a patient, hey, you can do a bridge to replace that tooth, you can do an implant, or you can do nothing and do a partial. So those 3 options are showing up as dollar amount diagnosed, but they're not going to choose all of those. They're only going to choose one. And so sometimes don't be alarmed if you pull that treatment statistic report and you're like, what the heck have we been doing? You want to actually dig into the unscheduled treatment list is the second component. So your macro view is the treatment statistics. Your micro view is, let's go actually pull an unscheduled treatment list. Every software has this, or you can build one in the dental software. let's look at quarter one, who all was due for treatment during that quarter and who didn't schedule. But when you're looking at that list, you're looking for repetitive trends, right? So if I pull that list and there's 10 patients on there and every single patient was recommended a crown, but we got a ton of fillings on the schedule. Okay, what's the why? Why can't we get people to schedule crowns? So, and sometimes there's not trends. Sometimes there's not. But a lot of times it's like, okay, this is pretty pervasive at this point. So those two categories, treatment statistics and then unscheduled treatment, they're doing the same micro look where you're auditing patients from that and going, first of all, is there any trends? How have we pursued this patient? Sometimes I'll step into a practice that's really good with their recare or recall program, and they're terrible with unscheduled treatment pursuit. Like there's none. We haven't pursued the patient at all. And that's a concern to me. Yes, I care about it from a practice standpoint, but I care about it from a patient care standpoint more than anything else. Does that answer your question?
It does. This is giving me a headache, man. It's a lot. Put you on the line for, like, in the playbook, maybe? Can you kind of put so for people that are tracking it and whatever, and you just want to make sure you're doing it right, maybe this document would still be useful for you to go. But for those of us that are like, okay, she knows what she's talking about, but ain't nobody got time for that. I'm just gonna, oh no, I'm just gonna go be in the operatory right now. Doing something to someone. I don't.
You're gonna do the schedule looks busy. We're good.
Yes. 2 patients. That's better than 1. We're good, ladies. We got this. So can you make something for the playbook tip, and then you'll put it on the hub as somebody wants to go back and kind of maybe just even a system for those of us that are way overwhelmed with this to just be like, okay, you may not have a Bethany to dig into all of this, but just even if you once a month for 2 hours, you did this.
Yeah.
At least it's better than nothing.
Something's better than nothing.
And the other thing I would say is that maybe it doesn't even have to be you necessarily for all of it. You probably have a team member that is either needing more hours and can at least pull reports for you, loves the math and loves digging through, or loves the, I really want to take care of these patients and I want to know why Mr. Jones didn't come back. Was it an insurance thing? Was it you, Susie, who didn't explain the insurance right? Was it you, Doc, who, whatever? Like, you may have people on your team that can help you fill in the gaps and try to figure out what little tweaks you might need in your system.
I agree. Yeah, I think it's worth all of those steps. And yes, we'll get you guys some support because I know it's a lot. It's a complex subject matter, but so critical to the patient and to the practice for that matter. So yes, if y'all don't know what we're talking about with Playbook and the hub, check the notes to this video and we'll link you to our subscription and to our hub.
Who doesn't know about the Playbook and the hub?
We can't assume that everybody knows. I mean,
if I know of it, no.
If I know as a main contributor. Fair. All right. Hey, thanks for joining us. I hope that you enjoyed this different format. Oh, wait, let's move back to our professional mode. Thank you. It's been a pleasure having you in the podcast today.
Thank you. Oh.
Thanks for joining the conversation today. We hope that you are comforted in knowing that you are not alone, but we also hope that you're walking away with some really great tips and tricks to try in your practice. We value your feedback, so please take a few moments to rate and review the podcast. Finally, we want to make sure that we're covering the topics that matter to you. So track us down on Facebook, Instagram, and Twitter, and let us know what topics you want us to cover. As always, please know that we are rooting for you today as you manage your dental drama.